One thing we all take for granted is our ability to walk. It's something that we require for everyday life, for pretty much everything that we do, whether that be going out to the shop, going out and catching transport, walking down to the park, or taking a walk with a friend. The challenge with osteoarthritis is that oftentimes when a person has osteoarthritis, they have pain, they have stiffness, they have reduced range of motion and potentially weakness in their muscles, and walking becomes more problematic. And some of the changes that occur in the context of osteoarthritis lead to reductions in a person's ability to walk. So that innate, really important, valuable part of our everyday life becomes more challenging and difficult. Oftentimes, those gait or walking changes are measurable. So what we're trying to get into today is how pain from osteoarthritis might change the way you walk, but in addition, what changes in gait or changes in walking occur in a person with deteriorating pain and function. We're really privileged to have Dr. Kathryn Baker, an assistant professor at Boston University, and Dr. Deepak Kumar, who's an associate professor in the Department of Physical Therapy at Boston University and the director of their Movement and Applied Imaging Lab, to talk about this really important and very commonly concerning topic that people bring up on a regular basis in clinical practice. Hello, Kathy and Deepak. Welcome to the Joint Action podcast.
Hi, David. Thanks for inviting us.
Great to have you both here. Now, just in the interest of the listeners getting to know both of you a little bit better, Kathy, if you go first, I wonder if you could just share with the listeners a little bit more about your background and what a typical day looks like.
So first, I had a long career in software development and management outside of public health. So I don't come from this field. My last position was director of engineering in a software firm. So I have a really practical approach to software, and there's no magic. So I just want to emphasize I'm not a clinician. Now, I work at Boston University. I've worked on caregiving and disability. I did a PhD in epidemiology. And I came to this group because I was interested in the variety of analyses that they do. Plus, I was interested in disability. Arthritis is the largest source of disability in the world. By the time I came to this group at around 2016, I myself was mildly physically disabled after being hit by a car and then diagnosed with multiple sclerosis. So I often walk with hiking poles or a cane, and I have to plan my activities for that. A typical day for me is spent at the computer. I'm a computer engineer, and I've always been on the computer. So I do research analyses, or I'm on Zoom.
Well, there's a lot of Zoom going on, so I think everybody's getting very familiar with spending long periods of time acquainted with their computer. So thank you so much for sharing that, Kathy. Deepak, what about yourself?
Yes, my background is very different from Kathy's. I'm a physical therapist, and I completed my entry-level undergraduate and post-professional master's in physical therapy from India, and then practiced clinically for a couple of years before immigrating to the US for my PhD. And I completed my PhD in biomechanics from the University of Delaware and advanced training in imaging from the University of California, San Francisco. And now I'm faculty at Boston University. So being in academia, a typical day for me would include some amount of reading, which would be new papers of interest or manuscripts or grants that I've been asked to peer review, some amount of writing papers or grants, meetings with trainees or collaborators, or meetings related to my administrative responsibilities, and occasionally data analysis, and very rarely data collection in the lab. And I wish I were able to do more time in the lab, but I'm fortunate enough to work with some excellent trainees who take on most of that exciting work. And I guess once in a blue moon, I do podcast interviews.
Well, welcome to this one, Deepak and Kathy. It's great to have you both along. The focus of today is really hopefully extending a little bit on the research that you've just published, looking at some of the gait changes that occur in people that have osteoarthritis. And I think that's probably a good place to start, if you don't mind. So I guess just to get things kicked off, how does gait change in osteoarthritis?
There isn't a simple answer to that question, but I can try. I want to preface by acknowledging that osteoarthritis is fairly what we call heterogeneous, which means that patients' experience with osteoarthritis can be highly variable, and the underlying disease in the body can be highly variable across patients. So gait changes can also be variable, depending on several factors, including how long the person has had the osteoarthritis, which part of the knee is more affected, and also how active they are, if they've had previous injuries, etc. But broadly speaking, people who experience chronic pain due to knee osteoarthritis walk slower. They take fewer steps each minute. And other characteristics can include reduced knee motion and increased muscle activity, and more loading or pressure on certain parts of the knee, depending on the pattern of osteoarthritis in the knee. They can also experience asymmetry, that is, the two legs move differently, which, if it gets extreme, can be visible as limping. And some people with knee osteoarthritis experience a phenomenon known as varus thrust, where their knee shifts outward momentarily every time the foot hits the ground. So there isn't one type of osteoarthritis gait. It's quite variable across patients.
Wonderful. That's a great overview of a very complex area. And really, just to emphasize what Deepak was saying there, it's an incredibly heterogeneous disease. So presumably people's presentation can vary markedly. Now, the complexity here is that a lot of what you've just described, some of which may be visible just upon observing a person walk, might require more sophisticated methods to ascertain whether that gait has changed or not. So how do you actually determine whether gait or walking has changed in a person that has osteoarthritis?
So in the context of the multi-center osteoarthritis study, the source of data for a paper, we're using gait capture during one of the study visits, and approximately 2,500 participants were involved. They wore sensors on their ankles and lower back while doing various walking routines in the lab. So this is a very large sample for this type of work. A lot of comparisons are not that many people. So the gait data in this study then came from participants who were walking a 20-meter course while wearing the sensors at a self-selected pace, so not necessarily a fast walk or something else. So the raw gait data was processed by a gait lab associated with the study, and they produced data with 40 to 50 characteristics of gait, which I will not go into, but those variables are then what we're using to try to do analyses to see associations of gait with various outcomes. The sensor devices were originally developed in studying Parkinson's disease, where there are issues in gait and an increased likelihood of falling. So they have a sense of the gait characteristics in a so-called normal gait as opposed to disordered gait. And some of the researchers from that gait center are co-authors on our work. Deepak?
Yes, thanks, Kathy. So the methods we used in the multi-center osteoarthritis study, which is a large population-based study, were designed to be simple and quick. For smaller studies, we would typically bring participants into what is called as a gait laboratory and use motion capture. So motion capture technology is what is also used for creating animation in movies or video games, also for assessing athletes' movement patterns in like golf or baseball or cricket. So in the lab, we would place several sensors all over the person's body and then capture their movement using high-resolution cameras. This allows us to measure a person's gait or other movements very precisely. For instance, we can measure how much the knee is bending or how much pressure they may be experiencing at various parts of the knee. However, this approach requires time and expertise that is not really feasible for large studies like the multi-center osteoarthritis study. So the sensors that Kathy described that we used do not really provide information about movement at different joints, but rather they provide a more global measures of walking, like how fast they were walking, how many steps they were taking every minute, how long were their steps, and things like that. And these measures can provide a whole wealth of information and can much easily be implemented in clinical settings, which is why we were interested in using these measures. And most recently, we have validated techniques to be able to measure some of these global measures of walking while a person is walking in their community. And we do this using a single sensor. And we are seeing that walking patterns in the community are A, different from what we measure in the lab, and B, may provide a more relevant measure of a person's function and potentially even pain.
Fantastic. And firstly, the sensors that you were using in the MOST study, the two sensors that you spoke about, do the measures that you capture there relate to those that you might capture in a more sophisticated gait lab setting?
That's correct. For these global measures of walking, like how fast they were walking, how many steps per minute, how long are their steps, and things like that, these simple sensors provide very accurate data compared to gold standard like motion capture. But as I mentioned, like these sensors don't provide direct measures of things happening at the knee, like how much the knee is bending, how much pressure on the knee.
Yeah. And the more recent work that you were just mentioning towards the end of that, Deepak, where you're actually putting a single sensor on people walking in the community, can you just tell us a little bit about that in terms of what the sensor is, where you place it, how long people wear that for, and again, how that differs from what you see in the lab?
Sure, happy to. So it's a small inertial sensor, which means that it has a couple of small sensors inside of it. They have an accelerometer, which measures the acceleration of the body, and a gyroscope, which measures how fast our body is turning or rotating. And then the person wears the sensor on their lower back. We attach it with tape. It's a very small, thin sensor, so they don't really feel it once they wear it. And they wear it all the time, like 24/7 for about 7 days. And then they send the sensor back to us, and then we analyze the data from the sensor to extract these gait measures. And we're seeing that when the people are walking about in the community, obviously they are not really walking in these straight, unobstructed paths, which is typically how we measure walking in the clinic or the lab. Like we set up a course where there's no obstructions and they're just walking straight and everybody's watching them. So we are finding that when people are walking in their home or in the communities, they typically walk slower than what we measure in the lab. And we are also finding that their gait is more variable, which means they have to adapt to the challenges that occur in everyday life. For example, they might be carrying something in their hand, they might be talking on the phone, or the terrain is uneven, or they're turning a lot, or they're talking to somebody else. So all of these perturbations or challenges during walking make their gait more variable, like their speed changes more, their step rate changes more, their stride length changes more. And the ability to modulate your walking in everyday life seems to be important. We're just starting to analyze these data, so I can't speak too much, but our initial findings suggest that this ability to modulate your walking in everyday life seems to be related to their osteoarthritis.
Yeah. Fantastic. Sounds fascinating work, and obviously really excited to see what you find as part of that study. But before we digress too much further, coming back to the study that you've just published, can you just tell us a little bit about what changes in gait that you found were associated with pain and function in the cohort that you examined?
Okay, so briefly, in the context of this analysis, we're measuring the pain and function outcomes at the same time as the gait data is initially captured. And then we measure pain and function measurements 2 years later again. So we were particularly interested in those with worsening pain or function, although some people may stay the same or improve. We didn't really address that. For worsening knee pain, we found several gait-related characteristics, some of which Deepak has mentioned, like greater gait asymmetry may be associated with pain. This is a measure of left to right symmetry in walking, where 0 is perfect symmetry, but higher values are worse. So these higher values have been seen in Parkinson's patients or elderly fallers. Another gait variable was a longer average step length associated with pain, where step length is the total distance walked divided by the number of steps taken. Longer average step length might be related to greater knee loading, which may reflect increased knee contact forces. And so interventions to reduce step or stride length have been proposed for people with knee OA, although I'm not sure if they've actually been tried in any trials. A lower dominant frequency was also associated with pain in this study, and this characteristic was closely tied to step duration and cadence. So for worsening function in OA, we found that lower cadence was related to worsening function, where cadence measures steps per minute. It's also related to gait speed. You can see everything is kind of related to everything else. So in one study, people with hip OA who received a biomechanical intervention showed increases in cadence that were then related to improved function.
Fascinating, Kathy. And if I could just expand a little bit further on just a couple of the more technical pieces. So you specifically examined in this cohort of about 2,000 people wearing the sensors, and you've categorized the people into worsening knee pain and function, and that's based upon change in pain and function from the beginning to that 2-year period, correct?
Correct.
Okay. Now, can you just explain to the listeners, just in case they're unaware of it, what cadence is and what dominant frequency is?
So cadence and dominant frequency are actually quite related. Cadence is another term, is the sort of the technical term for step rate, or how many steps you take every minute when you're walking. And dominant frequency is sort of an indirect measure of cadence itself. Basically, they're providing some very similar information as how many steps a person is taking every minute. And we found that a lower step rate, or people who walked with fewer steps per minute, were at a higher risk of worsening pain as well as worsening physical function as measured in our study over 2 years.
Now, obviously, this is an observational study, and sometimes strange researchers, such as myself, might extrapolate from an observational study to the clinical context and say, well, based upon this, we saw, at the beginning of the study that those people that walked slower or had a longer step length or greater asymmetry had a greater decline in pain and function. Now, this is not causative, and I'm not asking you to suggest that it's a causative factor. But if we were wanting to raise awareness around this particular type of research, how might you extrapolate from this to inform the clinical community about what it might be good to maintain, what it might be good to observe? Is there anything here for people out there who are living with osteoarthritis about the way they walk?
I think, David, you already raised a few good points, is that this study was not causal, it wasn't a clinical trial, it was observational. So, we can only interpret so much about whether gait causes these changes in pain and function. I also want to mention that the associations we observed were fairly small, and that we don't know at this point if we can change any of these gait parameters to an extent enough to cause changes in pain and function, if that makes sense. But at a very high level, because a lot of these measures are related to physical function, like exercise basically, I would feel quite safe in saying that based on the findings of our study, if persons with knee OA wanted to try walking with a slightly higher step rate, that is taking more steps per minute, it might be beneficial. However, I would caution that before trying this, they should consider speaking with their healthcare provider, because walking with a higher step rate can feel exertional and can increase heart rate. So it does feel like an exercise. So if there are any concerns about exercising, you should probably discuss with your healthcare provider before you try this.
Yeah, no, great advice. And I wonder, while we're talking about this, Deepak, if you might be able to just make a comment on some of the previous studies that have focused on trying to change people's gait, the success or otherwise of those trials and the maintenance of that change.
Yeah, excellent question. So understanding the relation of gait with osteoarthritis is not something new. People have been studying it for many years, decades. And as a result, there are several interventions that are available. These include different types of shoes, like minimal shoes, shoe inserts like lateral or medial wedge insoles, knee braces, and of course, canes and other assistive devices. Unfortunately, the evidence for any of these so far is questionable, largely because most of the studies tend to provide the same intervention to all the participants. And it's more likely that there's specific patients who might benefit from specific devices. But as of now, we don't have enough information to be able to guide patients toward the best device for them. Clinically, I would say that the patients should discuss these options with their healthcare provider and see any of them are appealing to them, because they're all safe and they are fairly inexpensive compared to some of the alternatives that we have for osteoarthritis. And in some parts of the world, a special biomechanical shoe called APOS shoe is available. There is evidence from one well-designed study that this shoe could help in reducing pain for people with knee osteoarthritis. And there are also some recent approaches to teach people to walk a certain way. For instance, walking with the feet pointing slightly more outwards or inwards, or trying to put more pressure on the outside of the foot. But there isn't evidence that these can be implemented by people in their daily lives. And then the last thing I want to say about this is that the goal of several of these interventions is to try to reduce the load or the pressure on the knee and improve the ability of the muscles to support the knee when people are walking about. So the first-line treatment recommendations for knee osteoarthritis remains as exercise, physical activity, and weight loss if a person is overweight or obese. So all of these interventions can actually potentially help with improving their gait as well. Typically, when you become stronger, you walk faster, your step rate can increase. And weight loss in particular is very effective for reducing pressure on the knee in case the person is obese or overweight.
Superb. I think it's wonderful advice and a great overview of the interventional studies that have actually occurred in that space. Just before we move on to the closing question, any further comments either on the research and or alternatively on the direction at which you're going to take this sensor-style research and how that might impact either observational studies or clinical trials?
This is probably the fourth or fifth analysis I've done where we're looking at gait as an exposure with different outcomes. So we're also looking at cartilage loss and widespread pain. So basically any outcomes that we can look at longitudinally in most, we are looking at those with gait.
Yeah, in our work, David, as I mentioned earlier, we are shifting our focus more to how individuals are walking in the community in their daily lives. So there's two things we are interested in doing there. One is trying to understand how walking in the community is related to the disease, like which aspects of walking seem most relevant for osteoarthritis. And the second thing is to see if we can extract one or more measures of walking in everyday life that can potentially serve as potentially secondary digital endpoints for clinical trials of osteoarthritis. As you know very well that measuring pain is the most important outcome, but it has challenges. So we are examining whether gait measures in everyday life can provide more context or complement the pain measures that we get from patients in clinical trials.
Yeah, no, I think it's a fascinating area and one that's definitely worth further investigation. I mean, as you well recognize, some of the limitations in the way we currently monitor symptoms and monitor disease place great constraints on our future therapeutic development. And so I think advances in that space are really warranted. Before I digress too much further, Kathy and or Deepak, do you want to just provide a piece of advice, knowledge, or wisdom for people out there who are living with osteoarthritis?
I'm just going to make a brief comment as somebody who is reluctant to use a cane or a walking stick. I don't have osteoarthritis, but you can walk faster and you can walk farther. And so I don't know, Deepak, how many of the people that you look at have walking sticks, but if you're trying to get more exercise, this is something that I would personally recommend. And so as you're doing studies of people walking, I would recommend, if it helps you keep your balance and be careful as you're walking, that I think would be a good thing.
Yeah, no, I agreed. And it's something we've not actually spoken about on the podcast before. So I really appreciate you bringing it up, Kathy. But just out of interest, because there's obviously some research in this space, both looking at the use of sticks and also Nordic walking poles. Do you use a stick or a Nordic walking pole?
I have a collapsible cane, which can go on an airplane with me. I'm not exactly sure what a Nordic walking pole is. I have ones that have little rubber tips on them and also, like hiking poles. Or you could use them skiing. Yeah, so the same thing, right?
Yeah, just slightly longer than a typical walking cane. Deepak?
Yeah, I think that's a great point that Kathy raised. I think particularly even if individuals do not want to use a cane all the time, they can use it for exercise at least, like walking exercise. And the only other thing I want to say is that I think for people living with osteoarthritis, taking ownership of their care is vitally important because there are rarely like only one right answer or one right solution for this condition. So the only way to do that is by education. So learning about osteoarthritis can allow patients to empower themselves and have productive and collaborative conversations with their healthcare providers. And there's several reliable resources for this, including this podcast and the website that I think patients can use.
Fantastic. Great way to close. For both of you, thank you so much for sharing a little bit of time with us, the insights that you're getting. And again, congratulations on the wonderful research that you're doing and the insights that it's providing. And I wish you both a lot of future success in that space. It's really, really valuable and important.
Thank you very much.
Thanks, David.
So as Kathy and Deepak explained really well, there are a number of changes that occur in a person that has osteoarthritis, particularly in the context of worsening pain and declining function, including the walking speed becomes slower, the stride length can be altered, there's reduced range of motion in the joints that are affected, And I think it's really important for people to be aware that that can occur in the context of osteoarthritis. Oftentimes people find it's more difficult to walk. I think the critical thing is to be aware that this is occurring, that osteoarthritis more than likely is related to this, and to seek help very early on in the piece, because there's a range of different things that potentially could be helpful in this regard, as Deepak explained towards the end of the podcast, including particularly exercise to strengthen the muscles around the joint, to improve flexibility, and hopefully also to improve the balance that can be impaired in the context of osteoarthritis. Sometimes even pain medication can assist in this regard. And as Deepak was saying, the core treatments here, particularly as it relates to things like reducing weight, considering the use of shoes or other devices like canes, walkers, or braces, might all be options in this regard. And so please go along and talk to your health professional about options here. The other important point that we didn't really touch upon is to think about pacing or activity modification. So pacing your daily activities to make sure that you can get done what you want to do in a day by spreading it out over the course of the day. And potentially also thinking about ergonomic adjustments. So, thinking about modifications that you might make to the home or work environment to minimize the stress and strain that you are putting on a joint. Not to suggest you become sedentary, because here motion is lotion, and we want you to remain as active as you can. So thank you again for the opportunity to speak to you today about a topic which we hope is really germane and important to your lived experience with osteoarthritis. Everybody walks, but in the context of osteoarthritis, that walking can become more challenging. And so we hope that this information is helpful in informing you about walking limitations and what you can do about those walking limitations. Thank you again so much for your support of the podcast, the opportunity to spend a little bit of time with you today. And between now and when we next have an opportunity to interact, please do look after yourself.
Thanks for listening to Joint Action with David Hunter. If you like our show and want to know more, visit www.jointaction.info. If you have any questions, you can email us at hello@jointaction.info and follow us on Twitter @jointactionorg. This podcast was hosted by David Hunter, edited by Vicky Duong, music produced by Jordan Hunter. The information posted on this podcast is not intended to diagnose, treat, cure, or prevent disease. Anyone seeking medical advice should consult a health professional.